gender identity as well. And site-specific swabs. So throat, rectal, potentially other areas. And that can test for things like gonorrhea and chlamydia at other places, or it can also screen for HSV, so herpes, or HPV, which is the human papillomavirus. People usually refer to it as, think about it as like anal genital warts, but it's known as HPV. So in regards to testing and getting all the right tests, this is a big thing that comes up a lot in practice. If somebody has had receptive anal sex, for example, so bottoming, or if they've engaged in giving oral sex, and they've never used a swab to test either their throat or rectal area, they may have an STBBI and not know. So this is a big issue. When we look back here, getting a urine screen for gonorrhea and chlamydia doesn't rule out that somebody doesn't have it in their throat or rectal area. So it's really important that when we're doing testing that we're getting, multiple sites tested as well. So if somebody's not swabbing, so let's say somebody has engaged in oral sex, with some partners, they've done urine testing, they've done blood testing, but they haven't done a swab of their throat, for example. What can happen is you can end up with a misdiagnosis, so the person won't even know they have it, and then it also gives them false confidence of their STBBI status. So a person may, they go to their doctor or maybe their prep provider, whoever they're going to, and they say, okay, well, your results came back and there's no STBBIs, so no treatment, nothing is needed. So that person thinks, not only do they not have something, but they'll go out, on apps, they'll go on dating, and they'll say, oh, I don't have anything, I don't have that because my doctor said so. And what happens with that? Well, this can increase the cases of gonorrhea and chlamydia. So to put things in perspective, 80% of our patients who test positive for gonorrhea and or chlamydia in their swabs, it is not showing up in their urine test. We've had folks who have switched over to our care who literally just had testing recently, hadn't been active, but they switched into our care and we usually do retesting with them. They get swab results and they find out that they have chlamydia, rectal chlamydia or something, and they're very surprised. Why are swabs so elusive? Why is it this, what's so challenging about a swab? Well, some in healthcare don't think about it. So we live in a very heteronormative society, so they're not thinking of things like, anal sex and oral sex, although really a lot of folks do anal sex and oral sex. So it's very odd that even with, a lot of doctors thinking of, cis heterosexual interactions, that they're not ordering those. The other issue is labs like Life Labs and Dynacare don't offer swabs in Ontario. So if you go to a Life Labs or Dynacare, they typically, I've heard some rare exceptions, they typically don't have swabs. So even if a doctor was to order that, when they go to the lab won't have any to do. However, there is a loophole. Those labs like Life Labs and Dynacare in the province, they do accept swabs. So the workaround is to basically either provide them to your patients or do them on site yourselves. The reason why some providers, especially online providers, aren't doing swabs, there is a cost to do that. So operationally, you have to prepare the swabs, you have to get the recs, you have to ship it out. So it's definitely a deterrent from a financial reasons not to offer that. We have always done it since opening back in 2019. And we actually are the only online sexual health service and prep service that actually does include swabs in testing. All right. So we have another person here. If I had an STBBI, I would be able to tell. I'm not the type of person it happens to. This I hear all the time. And it's obviously stigmatizing. It's not very productive, but it is very, very, very common. In my experience, people are often very surprised when they get an STBI. Sometimes the shock on the calls or when they come into the clinic, it's very surprising. And because they may not have symptoms. There's a self-perception that only certain types of people could get an STBBI. And we know that's not true. And this often turns into self-stigma and shame. I think it's a combo of a few things. I think it's because, we don't typically think about STBIs all day, which I guess makes sense. I mean, there's a lot of things going on, and there's a lot of stigma. So that combination leads to what I'm going to show you kind of in the next slide, which is, I mean, this hasn't been scientifically tested, but it's what I've seen in my practice, and I've dealt with, we've helped about 2,000 patients in Ontario since opening, so I have a pretty good background on this. And basically, this is what I see. So what usually starts out, this person will have stigma towards STBBIs. they will then project it onto others and cause judgment and have, maybe not the best interactions with some people, in their personal life and, in other places. This leads to their own fear and anxiety. It also raises fear and anxiety to other people. And this also leads to testing avoidance. So people are either fear going or just they don't think it's possible that they could have it because of their perception of how somebody could acquire an STBI. So with that being the case, I have on the corner there just to remind me about apps. So a lot of folks online may, if you're on like a profile or you're, talking to someone on Tinder or Grindr or whatever, however you meet folks, they may have in their profile, for example, their status or something. They'll say negative. But for some of these folks, they haven't been tested in a very long time, if at all. And a part of it is because they have this belief that they couldn't possibly have it, or that they would have symptoms, or they think it's sufficient that maybe they were tested like 2 years ago. So this has come up, and sometimes I do a lot of outreach on apps myself, just as a general health profile. I answer a lot of questions on like things like Scruff and Grindr, and I've been doing that for a few years now. And sometimes I'll just see profiles. They'll ask me questions. Sometimes I never reach out to someone, but if anyone does reach out to me, I will engage, and we kind of have these conversations. And so this kind of circle really comes up a lot, and I really try to break down that stigma and perception, because it's not just hurting other people they interact with, but it's also hurting themselves. So to clarify this in regards to testing and STBIs, they can affect anyone, different ages, identities, races, genders. It can occur from sexual activity. It can also occur through recreational drug use. Individuals who are less active can acquire STBIs, while more active may not. I know a lot of patients, they often share, sometimes they share their sexual exploits and encounters with me. And there's folks who, meet a lot of people, and time after time, STI has never shown up. And then we have some who, aren't really as active, and it does. So you never know. And you often will be asymptomatic. So the only way to know for sure is to get tested. And that's really important to bear in mind. With all that stigma and with those considerations, this is one thing that when I hear it on the phone, sometimes I'll talk to patients or people, and they'll say, "Oh, did my results come back?" Or, "Am I clean?" And it's hard because I don't want to judge somebody for using those terms, because we want to be open and we want people to learn. So I try not to be harsh on it, but in my internal reaction when I hear that use, just really kind of sets me off a bit. But I have to be respectful about it. So asking people like if they're clean as a way to check for STBBIs, it is offensive. It perpetuates stigma. It's not great practice. I would definitely not suggest it. So there's other ways to ask. If you want to know, when were you last tested, or do you know your status? If that's a question somebody wants to ask. On the other hand, the other person maybe doesn't necessarily owe you to tell you these things. For me personally, in my practice and just speaking with patients and over the years, usually the best thing is to share your status. And then if the other person wants to share, their last testing information, then so be it. So I just want to make it very clear, we are all clean. So there's other ways to ask those kind of questions. So here we have another person. So an STBI came up once and the doctor ordered pills to treat it, so it must be gone now, okay? So when we get treatment for STBIs, especially if they're bacterial, we would assume that if you go to a healthcare provider, they prescribe you something, then that would be the right thing to do. Unfortunately, we come across situations where this is not always the case. So before I get there, I want to put some things in perspective. This is a big chart, and you don't have to look at everything, but I want to kind of mention a few things. One, there are some STBIs that are bacterial, and if it's a bacterial infection, you can treat it with things like antibiotics. If it's a viral infection, like the ones below, it really depends on what it is. Viral infections are sometimes a little bit more tricky to treat. In the case of things like herpes, for example, that would become a lifelong infection in people. They may or may not have the symptoms, but they can have it ongoing. So the treatment, it's not like we're going to take an antiviral for a week and it'll just go away forever. And there's also different viruses like hepatitis A, hepatitis B, C, HIV, and things like that as well. So I just want to put things in perspective that there's different types of infections, so bacterial and viral, and the treatment options can vary as well. So if, let's say, you got a bacterial STBI, so let's say it's syphilis, it's gonorrhea, it's chlamydia, you want to be careful because some bacterial infections can be treated just with taking pills by mouth. That's fine. But some need to be treated with an injection, and that could be with or without pills. There's also resistant strains. So some are harder to treat. So they possibly may need different treatment than what is typically ordered historically. So even if the person's taking pills, they need to make sure it's the right ones and for the right duration. So is it long enough? Okay. And to also mention that antibiotics, people that are starting antibiotics, I mean, there are risks with antibiotics. I find in practice, a lot of patients don't really think about it that much. I mean, they're obviously happy that, they can take something that can clear up, gonorrhea or syphilis. But antibiotics kind of cause some stomach upset. Some people can get rare gastric stomach related conditions with taking them. There's also potentially resistance if you take antibiotics too frequently. So a few considerations there. Some that I just want to call out specifically, if you are treated, things like gonorrhea, typically pills aren't really best practice. Some online providers may order it just because it's easier just to call in the scripts to a pharmacy, but it really ideally should typically be treated with injection and pills, or you're going to start seeing high dose injection. So if anyone who has had gonorrhea before, typically you should be getting what's called intramuscular injection of ceftriaxone and azithromycin or doxycycline. What we are going to start seeing is a higher dose injection of ceftriaxone by itself potentially. Ontario Public Health hasn't really updated that, but it is in like newer guidelines, for example, with like the CDC and things like that. In terms of other things, so when we get chlamydia, not all chlamydia is the same. Whenever chlamydia shows up, your lab testing will actually go to another lab to assess to whether it's a more resistant or difficult to treat strain of chlamydia known as LGV. This chlamydia needs longer treatment. So, just getting the 4 pills of azithromycin or whatever people may have had before isn't going to be enough. Rectal chlamydia, we're seeing people use more doxycycline for 7 days instead of the typical single-day medication. And then for syphilis, we typically are seeing injectable penicillin as a preferred option. Okay. It's also important, we talk about prevention and ongoing care, that if somebody, for example, has had throat gonorrhea, that there is a test of cure. A test of cure is when you actually do a repeat test. Now, we don't do that for everything, but the one that really does come to mind would be a throat gonorrhea that really should have a test of cure a few weeks later just to make sure it's fine. Otherwise, potentially it could keep passing on to other folks. Okay. In terms of, once I touched on this a little bit, why are some people getting pills instead of injections? Well, if you're dealing with an online provider, an online clinic, it's a lot easier, and also they may not be familiar. The other option is go to public health. If the public health clinic is open or providing care, which has been really tricky across the province, they definitely have these in stock and can do that. If you were to deal with us specifically, we actually will reach out. So let's say you're going through us, we catch a STBBI, we would basically reach out to local clinics for you. We'd look into walk-in clinics in your area. We'd call 20 if we had to see who has it. We potentially could ship the treatment over to be injected locally. And if you are in the Ottawa area, which I guess a lot of you folks would be in, we do offer in-person services, which I'll touch on in a little bit. Okay. Are there any questions before I kind of just steamroll through? I don't want to just keep talking if people have questions. No? Okay. All right. So here we have another person, another patient, I guess we'll call it. I got all the tests I should do, including swabs recently, so I should know my status. So we have somebody who was tested, and we have someone who's tested recently, and it sounds like they got all the right tests. So this sounds promising. Okay, but wait, there's more considerations. All right, so when you're getting tested, and we think that we're treated or that nothing has come up, it's important that we are mindful that some of these symptoms may take a while to show up, and lab testing, there can be delays. So if somebody had, was sexually active, for example, like last night and went to get their lab testing the next day, it may not show up on their lab tests, or the person may not have symptoms. So it's important to know this. Now, this is a big chart. I'm overly excessive sometimes. But what the take home from this that I want you to appreciate is that sometimes it can take a few days, it may take several weeks, it take months. So for example, somebody who has, an HPV, so somebody who has showing a wart, that may not very well be from a potential risk exposure or potential sexual interaction someone had like last week. It could be from a very long time ago. So just gotta keep that in mind, okay? And those are kind of the take-home points that I want you to be aware. So just make sure when you are getting testing that there's a reasonable time frame. And if you need to retest, to be mindful of that, just to rule out if there has been a recent potential exposure that you are concerned about. So in terms of where to get testing, local sexual health clinics, if they're available, through a family doctor, if you have one, especially if they are supportive to testing and are thorough. Some organizations do host testing clinics. There's the home rapid testing kits / the I'm Ready program, where you can actually get an HIV testing kit to do at home, and either in person or online with us. Now, if somebody wants to get tested with us for an online appointment, people kind of ask, well, how do I do blood online? How does that work? That's usually a question I get when people are calling us to ask about this. Essentially what you do is, in order to get lab testing in the province, if you go to like a Life Labs or a Dynacare private lab, you need to have a lab requisition. So unfortunately, we're not a state in Canada or in Ontario where you can just walk into a lab and say, I want this at Life Labs. So what happens is we would have an online or phone appointment with one of our nurse practitioners. Lots of availability. We usually can get you in same day unless we are booked. Evening, morning, weekend, whenever usually. And after that call, we would just send the requisitions. We'd fax them over or email them to you, and you would go to a Life Labs or Dynacare to do. If you needed to do swabs as well, we would actually just ship them out to you, and then we follow up on the results. So to do that, you book that through the Prep Clinic app. You can call and text us. Also, once you are registered for testing with us, essentially, you have recs. So if you ever wanted to get testing again, it's a lot easier. You don't have to keep having appointments just to get requisitions. For the in-person Ottawa clinic, it's currently at 19 Main Street. We just opened this more recently. We're expanding to more in-person locations just because we have a lot of patients across the province. And sometimes it's just easier logistically. Having online care is great. It breaks down barriers to access, and that's really important. But what happens when somebody needs to actually be physically assessed? What happens if someone needs an injection? What happens if someone maybe is having some issues with their lab? I know there's discrimination and privacy concerns sometimes when people go to other labs. And some people just want the one-on-one attention. They don't want to have to do a phone consult or something. They want to see somebody in real life. So with that being in mind, we did launch really recently, a few weeks ago, Monday evening from 5:30 to 8:30. It's a small window because we're testing it out. We're seeing how it goes, and we can definitely add more days and time if needed. It's by appointment, no health cards required. So if somebody is, let's say they, are new to Ottawa, for example, or their health card isn't active or whatever, or they just don't want to share their health card information, they can do that through our clinic, and we sponsor that service for people who don't have health cards. They can get assessed, treats, on-site lab testing, so we actually do all the tests. There's a nurse that will do blood collection, that will do swabs, urine, all that, and you can also start prep. Our nurse practitioner on site also is fully bilingual and speaks both French and English. So in terms of prevention, obviously testing for me is a real passion of what we do. And even though honestly prep is kind of what allows us to function and do what we do, I'm very focused on the testing side. So with that being the case, partnering individual testing is super important. Needle exchange programs, not sharing drug paraphernalia and using your own products. Condom use, super important, internal, external. If you did want free condoms, we do ship that for free across the province. If you go to our website, you can actually do an order for that. Dental dams also are supportive. PrEP and PEP. So for those who are not aware, I feel like by now most people know what PrEP is. So I'm not focusing a lot on explaining PrEP. Because most people do, but just in very quick summary, PrEP is a prescription medication people can take if they are HIV negative to prevent acquiring HIV. It's typically taken on a daily basis, and you'd have to get assessed and get lab work to get started on that. PEP is emergency post-exposure prophylaxis. So if you are not on PrEP and you are HIV negative and you've had a potential exposure to HIV, within 72 hours, you can access this emergency medication that's taken after a risk. typically through a hospital setting, although I know sometimes hospital settings can be a little bit stressful, but that's typically the best plan for an emergency case because they can actually get you the pills to get started on it. And then HIV treatment. So being on treatment is prevention. I'm going to talk about that a little bit in a slide, but super important. I would say probably the most important thing is to screen people, get people tested, and get people on treatment. I mean, PrEP is, it's good. It helps with prevention, but if you really want to, hit the meat of what is, HIV and HIV prevention, it's really uncovering the 1 in 7 who are living with HIV who don't know and getting people on treatment, because people on effective treatment can't pass on HIV to their sexual partners, and also they can't pass it through pregnancy. So it's undetectable equals undetectable equals untransmittable. Sorry, I haven't eaten anything yet today. Other than that, this is also important. Prevention also relates to vaccination. So if you are being active, especially if you're being sexually active, you should consider hepatitis A, B, and HPV vaccinations. If you're on PrEP, these should be offered to you. I know some clinics aren't offering it, especially if they're virtual, because they can't deliver the vaccines, but they can still prescribe them for you to get done locally. Hep A and B is covered through sexual health clinics in the province. HPV is covered until a person's 26. We're currently working on providing vaccinations at our Ottawa space. We don't right now, but we will look into that. We typically try to help patients be able to navigate affording HPV vaccine if it's not covered as well. Okay. Antibiotic prophylaxis. So they're currently looking into whether, let's say, we know you can take PrEP to prevent HIV. They're looking into, well, can someone take like antibiotics like doxycycline before being active? So to prevent syphilis or chlamydia. I do know there are some infectious disease specialists and some doctors who have already started prescribing it for patients. We haven't really started doing that yet. It just seems a little bit early for us. We kind of want to see some more data. And also for people who are living with herpes, being on medication can actually suppress the virus so that they can reduce the risk of transmission as well. I do want to mention as well, even if somebody is not undetectable on HIV treatment, which is very common, most people on treatment are undetectable, even just being on treatment reduces the risk of transmission as well, even if it's not 0 like U equals U. So one thing I also wanted to touch on here is about stigma and PrEP. It's always been very odd to me when people have very negative connotations about PrEP and that as a prevention tool, that, a lot of slut shaming, a lot of judgment. And for me, it's very odd because I think to myself, if somebody got an HIV vaccine versus PrEP, I mean, we don't have one right now, but if there was one, what the reaction would be to that, and how many providers would be encouraging that, and how many people wouldn't say anything. I don't think anyone would shame anyone for getting the HIV vaccine. But somehow PrEP is looked at differently. And I mean, from a pharmacy, from a healthcare standpoint, PrEP is very similar to providing vaccine protection in a way. It doesn't affect your immune system, but it is protecting you while you're on it. To put things in perspective, when people travel to some places in the world where there's malaria, there's not an effective malaria vaccine. So what do? Well, they take pills to prevent malaria when they're away, and it protects them while they're away. So I think if somebody was getting an HIV vaccine, people would say, hey, that's amazing. Everyone should get this. That's very responsible. That's awesome. And then we're looking at PrEP, and on the flip side, and people, some people being like, I can't believe you take that. You must sleep with everyone. Why is your relationship open? All of these kind of questions. And it's very, the disconnect there. I don't understand it, I guess, because I look at it this way. But unfortunately, we have a lot of stigma still for PrEP, and that also prevents people who could benefit from it to possibly access it. For me, what I see when we have patients on PrEP, most patients are already at risk. So some people think, oh, if you're going on PrEP, it's because you want to drastically change your lifestyle and various things, which, to be honest, that's really no one's business. And if somebody wants to do that, they are entitled to have, the activity they want and the life that they want. But typically, people are already at risk. So when they're coming into being on PrEP, maybe they've had history of possibly having like a rectal STBBI before. Maybe they don't know their partner status, things like that. This person is taking responsibility and actively seeking out care. There's a commitment to taking it regularly, which is it's really impressive, even for people who are very young that have never had medication before, to be able to commit to taking a pill every day. I actually find it quite formidable. And people who are on PrEP are testing more frequently than off PrEP. So when you're on PrEP, you're getting screened every 3 months. That's a really great addition to our prevention tool. So it's not just taking the PrEP, but also being screened for all STBBIs as well. I do want to address a few PrEP misconceptions. So I'm not going to talk a lot about, why everyone should go on PrEP and how affordable it is in some ways. Like, that's fine, but I think a lot of the deterrence for people is other things. So we get a lot of folks who they think because maybe they're an inserted partner or the inserted partner at the top that feel they don't need PrEP. But the truth is, sorry, I just noticed some chat is in the corner there. Yeah, so I mean, it doesn't make a difference the position in from being active. I mean, PrEP is still relevant. There's still risk. Where there's risk, you should consider it. PrEP causes lots of side effects and is risky. Honestly, from a pharmacy standpoint, we deal with lots of medications, and I've been a pharmacist for like 11 years now, and I don't consider it a more risky medication compared, like when we think about medications people take on a daily basis. It's being monitored very closely, probably more closely than a lot of medications that have much higher risk profiles. And most people do pretty well. 90% of our patients on PrEP don't have side effects. Those that do, it's usually minor stomach upset, headache, feeling tired. They usually get better and go away. Now, are there cases of people who get very, very unwell on PrEP or does not go well with them? Absolutely. You will always find some people who will have not the best reaction or won't do well, but it's very rare and very far in between, few and in between. The other thing is we do monitor kidney function on PrEP. Every 3 months. It's very unusual to see a change in that. We're doing it to be proactive. If there was a significant change, patients are told. If there's a major change, things are typically reversible. It's not something that we typically worry about. There's also a newer formulation of PrEP on the market that also may have potentially further safety from a kidney bone perspective, and we do try to connect people to that. So when people come to us, we make sure they know all the options, and that includes, the original PrEP, the newer version of PrEP, and they can kind of make the right decision. Next, we have PrEP is only for gay cis men. I mean, we really reach out to a lot of folks, so we get a lot of people from all backgrounds. 1 in 4 people being newly diagnosed with HIV are women, so it's important that we aren't having this mindset that it's only for gay cis men. It not only kind of stigmatizes a group, but it also leaves some people out of the conversation who really should be included. So I'm always, always pleased when we get, more and more different types of people coming through our care, which we have several different types. I get this a lot. Well, if I have to take PrEP forever, if I start PrEP, I'll have to take it forever. That's not the case. Some people, life's change. Sometimes they want to be on PrEP for a while. Sometimes they want to take a break. That's fine too. It really depends on the individual. So I don't want people to think that once they start that pill, that means they're going to be on it for the next 30 years. It doesn't mean that at all. The other one is the only way to take PrEP is every day. So there is another way to take PrEP, which is known as the on-demand method, where someone takes PrEP, a couple of tablets a few hours before potential risk exposure, and then 1 tablet once daily for 2 days after. For some people who aren't going to be, active all the time, or they're going to have a change in their life a bit, this works really well for them. It really depends on the individual. Obviously, if somebody is, not planning out activities very, ahead of time, which a lot of people don't. I mean, life happens, but if they do, it kind of works for them. There are some populations where on-demand isn't appropriate. So like cis women, trans men, that would not be an option for them. But for some people, it is an option. PrEP is super expensive. I mean, yeah, PrEP is very expensive. You just casually walk into any pharmacy with a script and have no discussion on coverage and just kind of go. PrEP's like generic PrEP's like $250 a month. Like, no one can afford that. I mean, I guess some people can, not a lot of people. But there are support programs. I mean, right now you can get the first 3 months free. There's a PrEP Start program. OHIP covers it for people under 25 and people over 65, people on disability, people on, who have different supports. Ontario Works, it's covered. It's covered through the NHIV program for Indigenous individuals that qualify for that. And it's a lot of people have private insurance, and private insurance covers the bulk of it. If a person doesn't have full coverage, there are support programs. I mean, we have a program called PrEP Saver. Since opening, the majority of our patients actually pay $0 on PrEP. So we always are able to navigate those. So patients who normally have to pay like $40 a month out of pocket typically don't have to pay that with us. Or if someone has no insurance and they are, have a health card, they can apply to Trillium. And some people have very high Trillium deductibles or amounts they have to pay. We support patients with that as well. The bulk of our patients don't pay out of pocket. And my understanding is we are the most affordable in Ontario for PrEP from talking to patients. I could be incorrect, but that's my understanding. I know some do market, discounts and things like that, but just because we're very project focused and getting medication out the door, we're able to kind of probably go a little bit farther than a lot of people would. So just some things to keep in mind as well. If you also, let's say, do not have a health card and you have no coverage, there are programs as well where you can get access to PrEP as well. So definitely reach out to us if these are considerations or concerns you're having, or if you know anyone that's had those concerns. We also help with affordability support for HIV treatment medications as well. I don't know why, but we come across people all the time that are paying fully for their HIV meds sometimes, or way more than they should be. So definitely reach out to us if that's a concern as well. The last is PrEP makes people more sexually active and increases STBBIs. So there were some original studies that were suggesting that it doesn't really seem to change behavior. They call it risk compensation. It's been mixed. There's been some studies suggesting that there is a slight increase. There's been some studies saying it hasn't really. Some of them are suggesting, well, people who are on PrEP are just getting tested more frequently, so you're finding these. That's why they're popping up. Ultimately, I don't think it really makes a difference, to be honest. I think people, if they're going to be active and they're going to live their life, they need to have the tools and supports, if that's the case. But it seems like it's a bit of a mix on this one. So just FYI. Another thing people always say as well is everybody's on PrEP. So they go on an app maybe and they see that, like on Grindr or Scruff, it says, on PrEP or something. But the uptake in Ontario hasn't been like amazing. About 1 in 10, I think it was estimated a couple of years ago that 1 in 10 people who could benefit from PrEP were on it. So even though it seems like a lot, and even if 10% of people on an app is actually a lot, it's not everyone. So just some tips. I would say that if you're not sure about PrEP, and we get patients who come to us who get testing that seem to be at a higher risk, or we get patients who want to take a break from their PrEP. And I'm always really, really nervous because we've had patients who either decided not to start PrEP with us or have been off their PrEP, and then they contact us later because they need emergency PEP. And it's just like, we really try to help them, to realize that it'd be good for them. But I mean, ultimately, a person has to decide what's the best for them. So for that, I always suggest, if you're not sure about PrEP, but you think you may be at risk, at the very least, get a supply of PrEP, even like that first 3 months free supply, and have it for on demand, so that even if something was to happen or come up, at least you have it. So you have the option and you have that freedom to know that you have some extra protection. It can be very stressful to possibly need emergency PEP. Sometimes, depending where you are in the province, Ottawa shouldn't be, I don't think, as bad. I can think of a couple of pharmacies that should have it regularly, but in some parts of Ontario, it's hard. We had a patient literally today. We were helping from Niagara Falls, and we called, I think, 8 pharmacies, and no one had it, which was kind of concerning. So something to think about. Okay. If you have ever needed emergency PEP, or you have acquired a frontal, vaginal, or rectal STBBI, highly, highly recommend considering PrEP. So, we definitely have patients who have had rectal chlamydia or rectal gonorrhea. And, I tell them, I say, FYI, if that person that you were with had HIV, I mean, there would have been a pathway for transmission if that had happened at that moment. And if somebody also had gonorrhea or chlamydia, that can further increase the risk of transmission as well, of HIV as well. So something to be mindful of. I also am really big on condom use. One of the reasons we have a free naloxone condom shipping program, and we also send lube, and we send the good lube, is that condoms are still cool. I love condoms. I think they're great. I think some people, it doesn't work for everyone, and that's totally cool. I get that too. But condoms do protect against some things HIV does not, including things like gonorrhea, chlamydia. With that being the case, we also know condoms can break. We know, that doesn't work for some people. And we also know that condoms don't protect against everything. Things like herpes and HPV, if it's not covered by the condom, there's still risk of transmission there. So just be mindful of these things as well. I want to touch back on U equals U because I feel very passionate about this, especially as a prevention tool. It's part of why it's literally our logo. And that is that a person living with HIV, once again, unaffected treatment, cannot pass it to a partner or through birth. Large studies, I get a lot of patients, even ones, we put it on their bottle. Literally, U equals U is on every single patient's bottle. It's in all the documentation they get. And I get calls, people very anxious and fearful saying, you know, Andrew, or Drew, I guess I go by Drew more often, saying, you know, Drew, I just had, you know, I was with somebody and they told me they were undetectable and I don't know what to do. And I'm like, well, I mean, look at your bottle. It tells you what to do, right? And we just have to kind of reassure patients and let them know that. And I think it takes a while for people to wrap their head around this concept, especially if they haven't really thought about it a lot. But it's zero risk if somebody is undetectable. I mean, they'll have to keep taking their medication, but they can't pass it on to a partner. So people need to realize that, and we really need to really focus on treatment and getting people in testing and getting people on treatment. Okay. Now, obviously, it's hard. Sometimes there's a lot of barriers to access testing. There's barriers to treatment. There's a lot of challenges why some people cannot stay adherent to their medication. And I don't want to make it seem like anyone who's not undetectable somehow has less worth or is different. No, but we want to be mindful that we want to try to get people to undetectable if we can. And we should also really try to break down any barriers to that so that people have more access to that. Okay. And to put things in perspective, if somebody reaches out to us and their only partner is undetectable and they're a monogamous relationship, we do not recommend PrEP. So our clinic won't really prescribe it. Sometimes we will for the first few months. We've had a few patients where they will start on it just because there's a bit of anxiety. But after like usually the first fill or second fill, they kind of are like, okay, you know, I've learned enough, and honestly, I'm not going to continue on it. Now, there are some people who are with somebody who's undetectable that are in open relationships. So yeah, obviously you would still want to consider that. So once again, testing and starting treatment is integral for prevention. These are, I gotta make it very clear that these are super crucial. And in summary, testing needs to be thorough. So we don't want to miss things. We want to make sure it's timely. We want to make sure that we're getting things done properly. We are all clean, that we're fighting stigma, that we're not self-sabotaging ourselves in the process of having these beliefs and thoughts and projecting onto other people. And knowing prevention is much more than PrEP, because prevention doesn't just mean HIV prevention, and that we obviously know testing and treatment are super crucial. So U equals U 100%. You can learn more at preventionclinic.ca, Instagram at the PrEP Clinic, Facebook, Ontario Prevention Clinic / the PrEP Clinic. You can also call, text, you can DM us. We're always around. We're accessible 7 days a week to midnight. We text and we reply super quick to people. I get things forwarded to me after hours. So, you know, I'm up at 1 in the morning answering people's questions if they need it. And we're a really good resource. We have a lot of background on what we do, and we have I'm a certified HIV Pharmacist, so I've been working in this space for a while. I have additional training in it. Our nurse practitioners, we have people who are very experienced in this field. One of our NPs who actually works in Toronto, for example, he actually works in the HIV department of a hospital in Toronto. So a good background there. Other than that, that's pretty much everything I was going to say today, but I'm really happy to answer questions and hear thoughts, and even hear your thoughts in general, even if it's not a question, just some feedback and some of the things I talked about today.
Thank you so much, Drew. I'm just going to stop the recording and then we can start the question.